And I'm delighted to welcome Holly, Donna, and Charles as they walk us through demystifying privacy and research uses of administrative data. Just a quick note, we will be recording the presentation, but not the Q&A that will happen after the presentation. So welcome you three. At this point, I'll just hand the floor over to you.
Thank you very much. I'm going to actually just start the presentation by introducing a few things, and then I will turn it over to my fellow speakers. But before we do anything, we want to do an Indigenous recognition, which is a little different when you do things virtually, but we would like to begin by acknowledging the land on which we gather as the unceded traditional territories of many Indigenous peoples from across Canada, including in my case, where I am in West Vancouver, of the Squamish, Tsleil-Waututh, and Musqueam nations, and we are grateful for the opportunity to do so. So a big welcome, and also a huge thank you to the organizers of the My CERN Cheer webinars for inviting us to speak. We are so incredibly pleased to be here to talk about these issues with you, and we really do hope that at the end of our three presentations that you just feel super free to ask whatever you want to us. That part will not be recorded. But I do just want to give a little blurb about who we are. You may know some of us independently, but we come together as a group because we are all members of the Health Data Research Network Canada privacy team. So that's the HDRN Canada privacy team. We provide privacy guidance to HDRNet Canada and its partners. HDRNet Canada is a not-for-profit organization that brings together provincial, territorial, and federal organizations which hold and manage data to share expertise, identify opportunities for collaboration, and foster innovation while respecting public expectations and Indigenous data sovereignty. These efforts serve to meet the HDRN Canada mission to improve health and well-being by making data accessible to researchers, institutions, and government agencies across Canada for research that will foster improved health outcomes for all Canadians. So that's who we are. That's who we're, as we present to you today. And my fellow presenters are Charles. He's an Associate Directory Repository Manitoba Center for Health Policy at the University of Manitoba. He's going to talk a lot about the background in this area and regulations. Then there's me. I'm the Director of Privacy and Access, PHSA Research and New Initiatives. So that's the Provincial Health Services Authority of British Columbia. I'm going to be trying to contextualize all of this within the REB and ethics domains. And then finally, we have Donna, who is our fearless leader. She is the chair of our privacy team, and we so appreciate all the work she does to bring us together and keep us going forward. She's also the privacy officer, New Brunswick Institute for Data Research and Training. She's going to be talking about the HDRNet Canada privacy team and our newest product for you. And like I said, at the end, we're going to have lots of time for Q&A, which is not recorded, so you can ask us anything you want. So with that, I'm going to turn the very first presentation over to Charles. And Charles, when you want me to forward a slide, just let me know and I'll do so.
Absolutely. So you can forward the slide now. So the first thing that I wanted to do is just give you a little background. So what we're talking about is administrative data, and in most of our cases, administrative health data. So this is data that's really been collected for managing a system. So if you think about physician billing, for example, physicians want to provide a service, they want to help us get better, treat diseases, those kinds of things. They also want to get paid. To get paid, you need to have a service code, and usually you want to have a diagnosis code that goes along with that, and when that service actually happened. So that's administrative data. It's really used for running a system, paying a system, who's come into the hospitals, what they're there for, managing the hospital program. In some cases, these will be clinical programs. So somebody running, like in my province, there's a lab that looks at MRIs or bone mineral density screening, those kinds of screening programs. There's a few other programs, but really they're set up for running a system. Because they capture information around, like I said, maybe diagnosis codes, when things happen, where people live because their insurance coverage is there, we can use this for secondary use for research. So a researcher may have a question about, I'm interested in the number of diabetics in the province. So they can go to that physician billing data and say, who has been coded for being treated with, for diabetes? or go to a drug data set, who's getting metformin or insulin, to pick up information about who's getting diabetes. It's not its primary use. So sometimes we have to be imaginative about how this data goes together. Lots of the data, so I mentioned diabetes earlier. Often when we look at a diabetes code, if there's only one in existence, or a hypertension code, there's only one in existence, we can't actually say that that person has hypertension or diabetes. We have to go looking for other markers. So sometimes these administrative data sets are a little complicated to use, but it gives you a broad population-based look at the information. So if you're thinking about where I live in Manitoba, people go to see a physician, and there's not a bias against, I'm going to come back to this question though, there's not a bias against, did I go see somebody for this condition? Was I doing this 5 years ago? Did this happen in my family? So it is collecting all the information that's routinely collected around providing services. So there isn't that kind of recall bias that's there. So it's really great. It's really great in that it covers the whole population. So, or the whole population at risk, or the whole population of people seeking services. So you're not, so sometimes surveys are limited to a certain group of people. You can ask the direct question, but you may not get everybody in the province, and you have to do some statistics to get back to that. So I'm going to skip over the kinds of research, because I've mentioned a few kinds of research there. You're looking at population-based collection of information. You can use it for identifying services or diagnoses that happen in the population. So it becomes very powerful and very efficient to use this kind of data. It's not, I can go to the next slide. It's not the Wild West. I'm not sure I'm allowed to say that here, but in every province or every jurisdiction, there is rules around using this data. And these come as part of personal health information or personal information or health information acts, which really provide some baseline guidance towards using administrative data. So it exists for the public good, it exists for collection, for running a service, but that doesn't mean that Donna, for example, can't just go into their physician data and go, oh, I want to look at stuff. There's a process that needs to be followed. In most cases, this data comes to the units that use it as de-identified data as well, but that still doesn't take the responsibility away for the original people that this data is about. So the legislation exists in every place, and it provides some rules or guidance around using data. One of the complicating factors, at least here in Canada, is health is the provincial responsibility. So health information is, by its nature, legislated in every province, and there's little differences that happen between them. There are federal legislation that cover where data is collected federally, the Statistics Act under Stats Canada, for example, or the Privacy Act, PIPEDA, I think everybody knows. C11, is that right? Is the replacement that's coming down the pipe. But that acts at a federal level, and PIPEDA, as an example, acts at the commercial end as opposed to that publicly collected end. To cause some more confusion is some of these acts don't only stand on their own. So we have an act in Manitoba, which is the Personal Health Information Act, which really tells us about how to collect, disclose, use information. But if there's something that's interacting with the mental health care system, the bar is raised. So there's another act that changes the way that FHIA may be interpreted a little bit. So that's something that you need to look at as well around the legislation and regulations. The other piece that I know we in this privacy group at HDRN Canada have been working with is the distinction between legislation and interpretation. So we saw this lots and lots around privacy as the privacy nogs, can I call them that? Ooh, better be careful. You can't do that because it breaches somebody's privacy. Well, as long as the rules are followed, maybe you can, or maybe you can use it in a certain way without having individuals identified. So there's this question around interpretation and legislation is a complicated one. I'm going to go to the next slide. So the legislative landscape does allow administrative data to be used for research. I will say, I'm going to skip down a little bit. I'll mention it right now. The default starting point around collection, disclosure, and use is making sure that there's consent in place. There's places where you can get a waiver of consent, and I think Holly's going to talk about this a fair bit. But when we're using this data, I always like to start with, okay, consent is the default starting position. Is there a reason that we can get a waiver for consent? So in my case, administrative data, you're often not contacting individuals directly. So, and the kinds of questions that we're asking are very low risk to an individual in the population. So those are some of the things that we look at is, are you poking somebody? Are you talking to somebody directly? Are you putting them at risk for some reason? Is there a public good? And these are questions, we had a little conversation right before this around REBs and what the responsibility of a research ethics board is. And it's really to look at, you come with, okay, I've started with consent. I don't think I need to consent. One of the examples that people use is, well, you can't contact people that have left or died. So this is one of the pieces that the research ethics boards helps us with. Is this a reasonable waiver reason to get to? The other one is removal of identifiers. And this causes lots of problems around what are identifiers and how do we remove them? And are there other things in the data that can identify somebody? So lots of the legislation has reasonableness clauses in there and or clauses around removal of information and not being able to identify even when you're linking it or connecting it with other pieces of information. So those are the kinds of things that the legislation gives us in the background. But I always start with that consent question. I got to go to the next page, I think. Across all the provinces, there is commonality and there's challenges. So collection and disclosure of data. Collection of data, usually it's the front end, and often for administrative data, we don't deal with that, but we deal a lot with disclosure. And there's rules around disclosure, and then there's rules around use. And there's confusion between what is disclosure and what is use. I mentioned earlier that we often work with de-identified data. So we take the data, we strip all the direct identifiers off, but sometimes we need to go from that hospital data to physician data. How do you do that? Well, there's a linkage process that harkens back to those individuals to begin with. And how that's done, where that's done becomes important. Is there a place, a secure place within your environment or a particular environment that the linkage can be done? Or is there a third party that just has the identifiers, but no other information, a trusted third party for doing linkages? Across the board, approvals are required. So I think all the legislation speaks to a research ethics board or institutional ethics board or a review board. Many of the places also have further privacy or privacy impact requirements or data disclosure requirements. Some of the challenges go with those areas. So if I think about disclosure and access across multiple jurisdictions, in Canada right now, I think I said that health data in particular is the provincial jurisdiction. And the interpretation of the legislation right now is that data cannot flow between jurisdictions. So data collected and for administrative purposes in Manitoba has to stay in Manitoba. I think Holly and Donna might get back to this a little bit with the consent questions, but that's the interpretation right now. And it does cause some issues around access and use if you're using international kinds of studies or national kinds of studies. Another piece that we do, and I think we talked about this beginning, is there's a large portion of our population that represents a unique cultural group that really has signed treaties about their use, their access, ownership, and control of the information about them. And we need to recognize governance and considerations about our Indigenous populations. I'm going to mention consent again. Consent, I'm going to keep coming back to this because consent allows you to do things that you agree to or things that people agree to, but it's also sometimes constraining because they're agreeing to that. So this is where that waiver of consent comes in, that you go back to the institutional review boards and say, can we do this research? Is it appropriate with a waiver of consent, or do we need consent? And then what is in that consent? And how do we make sure people understand that we're going to take their RCT or their survey information and connect it to this administrative data? Everybody has publication review requirements. So when you go to publish, there's an assumption, at least, I'm not sure if it's in all of our legislation. Donna can tell me, but there's the assumption that anything that's being done with this public data goes public at the end. So somebody can't ask for data that they're going to look at a particular widget, if you will, and they're going to use it for their company only and never tell anybody about it. There has to be this allowance for any research to go public. And all of us have privacy training about all of these pieces as well. And that's another piece that's in the regulations and legislation. I think I can go to the next page. I'm just going to mention on the back end, all of these systems that we have storage systems and analytic systems. And we have to make sure that those systems are safeguarded for people coming in. And more where we have lots of people wanting to come in and do research from across the country, is how do you deal with that remote access? I'm not going to say anything more about that other than some of the legislation and regulations talk about that. It needs to be considered. I can go to the next page. Data curation. And I think this is my last slide. I want to say data curation becomes so important when we're working across multiple jurisdictions. So I had a conversation with one of my coworkers this morning about physician billing. So physician bill, we talked about this fee for service. There's a tariff code or a service code and a diagnosis code, but actually what goes into that data changes. So Ontario, Manitoba, Saskatchewan all have different service codes. So we need documentation that provides the standard, the consistency across the province to allow us to understand that. It also gives us, how do we deal with those quasi-identifiers when we're working in our data? I mentioned this very early on, there's always a question about data equity. So one of the great things about administrative data is it gets collected across everybody. And I'm going to put in quotes, the same. But there are systemic things in our system. So I work a lot with child and family services data. And there's some systemic things in our society that allow people or disallow people to actually wind up in the data. And I think this is one of the things that we more and more that we need to recognize, especially as we get into AI or large big data analytics, where you're taking the data and you're coming up with a result based on the data that's there. But if your data has a bias built into it, that may trickle over to your answers. I think I can go on to the next page. So the last thing, Holly mentioned this at the beginning, we are part of the Health Data Research Network Canada, and she gave us some background. But what I wanted to I mentioned legislation in every province is different. The metadata in every province is different, if it exists at all. And one of the things that HDRN Canada is striving to do is provide a single source for researchers to access that gives us what is a common way to access data in multiple jurisdictions. So a researcher that wants to work in Ontario, New Brunswick, and BC, instead of trying to figure out all the nuances and the regulations for submitting, they could go to HDRN Canada or the DASH process, the data access process, and say, I want to access here, help me deal with all these different jurisdictions. They also have an inventory of all the different data resources in Canada in every jurisdiction. Remember, I said there is this complexity where administrative data doesn't always give you the answer. It gives you a constellation. There's an inventory of algorithms that allow you to build those, and those are being expanded all the time. So within HDRN Canada, there is a number of working groups that cover data access, that cover that algorithm and some data harmonization, that cover modeling and informatics, that flow of information. Back to the Indigenous research, we can't do this work without collaboration, input, and understanding. And that also goes with public engagement. So how do you ask questions? How do you reach out to the public to make these things understandable? And of course, we're all part of the privacy working group, the three of us. So thank you, Holly and Donna, for letting me talk first. I think we're going to go on to Holly. And hopefully I'm not too far over my time.
Not at all. Perfect. So now it's me, it's Holly. I don't know who's in the room or who's listening right now, but I'm assuming many of you are from the CHEER project, and a lot of from the research ethics community. So maybe you know me. I come from an ethics background. I am now the Director of Privacy and Access at PHSA, but I do really want to take some of the stuff that Charles was talking about and some of the stuff that Donna's going to talk about and contextualize it in our field of bioethics. And the first thing I want to talk about is why we should care deeply about access to administrative data. I think that sometimes we, if you're like me and you're serving the research community, you care about it because you want to get the researchers what they need to do their work. But actually, there's really, really important ethics reasons why we need to care deeply about this issue and engage with it. The first is this idea that inaction is value neutral. I'm sure everybody is like me right now, where you're getting thrown at, all sorts of really complicated questions in this new world that we're in, trying to cope with everything being virtual and COVID and all this kind of stuff. And there is a tendency, I think, for some folks in our community, me included, is when you get these questions to freeze. You're not sure what to do. You haven't done it before. You don't have a process to rely on. Nobody else is doing it. Maybe you're the first group to do it in Canada. It's scary. And there's this idea, I think, sometimes that if we do nothing, then we're safe. No one will get hurt if we do nothing. There won't be a privacy breach. There won't be, an ethics deviation or anything like this. We're okay, and no one's going to get fired. The institution won't get in trouble. Blah blah blah. But we know that's not true in ethics. We know that everything has moral consequences. If you act, there's a moral consequence. If you don't act, there's a moral consequence. And here are two really big buckets of consequences that I want us to kind of think about when we're thinking about administrative data. The first one is this idea of the broken promise that we have with our research participants. Donna and Charles and I could talk all day long about, participants who in very good faith have signed consent forms based on the informed consent relationship that they have with their study team, intending fully for their data to be shared and linked and all these kinds of things. And we know it's not happening. That is a broken promise to that research participant who gave those data, gave those biospecimens in good faith for them to be used for the public good. So there's all these initiatives, and I just grabbed a few that I'm working on right now that I thought most people would be familiar with, that are really dependent on us being able to get it together with the consent process. So one is the CIHR Pan-Canadian Genomic Consent Initiative that's out of the Institute of Genetics at CIHR. It's a whole bunch of us trying to get some common language so that we can agree that when people have this certain language in their consent forms when it comes to genetics and whole genome sequence, that their data can then go on and be shared the way that they intended, and it's not going to sit on a shelf somewhere, because that's what's happening right now. Of course, there's the network that we're part of that's really dependent on being able to share data according to what people have consented to, but also with what REBs have approved if it's a waiver of consent. There's the Terry Fox Research Institute Marathon of Hope Virtual Cancer Center, very dependent on both unconsented and consented use of data that's getting started up. And then the CHEER project, which we're all familiar with, which is an attempt to have a centralized REB review process for pediatric research in Canada. And to be able to do that, and for consented studies, we need to be able to honor what participants have agreed to. The other big bucket of consequences is around this idea of therapeutic orphans. I'm sure most people here are probably from the pediatric community, so we all know this. What a therapeutic orphan is. It's if you don't participate in research, you can't benefit from it. This is now well beyond the pediatrics community, and what I'm seeing now is a lot of, especially in times of COVID and everything, that there's all this desire to do artificial intelligence and whatnot. And like Charles was saying, if everybody is not included, everybody's not going to benefit from it. If we leave a health authority out because they're difficult to work with, or a whole province out because we can't figure out their jurisdiction or whatever, all those people are not going to be able to benefit, and the people that they represent in the future will not be able to benefit from that research. And that's how we end up with racist AI and sexist AI, and Google search it. It's a really fascinating world, and I'm sure you guys have all heard about it. But that's why we need to make sure that that everybody is included in these kind of research studies. And we know that we have a broken system in Canada when it comes to data sharing. We know that. I'm sure, you know, when things were set up at one time, I'm sure it was very, very sensible, but things have changed and we need to do national work and international work. It's not enough for data to simply be shared within our little provinces. It has to be shared all over the world to be meaningful and impactful. And I threw up one article here from the news, but I could have, you know, this is from the beginning of the pandemic, but there's been tons of people that have now recognized at very high levels that, oh, holy smokes, we can't share data in Canada. This is the problem. Yeah, it's been a problem for a while, but it seems like people are really recognizing that now. But what I guess I really want for people to understand, and why I think it's so important to hear from folks like Charles and Donna, is that this is not a matter of simply turning on the tap now. It's not like, okay, oh, we didn't share data before, turn on the tap, everything's fixed. I look at some of the slides that, you know, Charles talked to. It's an incredibly complicated legislative landscape when we're talking about across Canada or in the world. So the group that we're supporting is trying to address that at a national level, and I think that's great. But we all have to work together, all of us, not just the privacy community, but the REB community, patients, researchers, everyone, regulators. We all need to work together to make it work, because even when we're all together and working as hard as we possibly can, it's still hard work, and it takes a lot of effort and a long time. And the product that Donna's going to be talking about, I cannot tell you how many hours we've all put into it and how many people have contributed to it. And it's a small step forward. So I just want to, I hope that, you know, when COVID is, you know, resolved and managed, thank goodness, hopefully soon, that we'll keep this kind of community spirit that I think we have right now and continue to work together on these really difficult problems. And then I also just want to point out that, you know, the REB community already has done some really fantastic work in this area, and the research ethics and bioethics community. We already have really sensible criteria for how to get approved for a waiver of consent for both data and biospecimens in the Tri-Council policy statement. I'm putting out the articles here. I'm sure you guys know them. Very sensible. All the criteria you have to meet are very sensible. I've highlighted a couple here in red that should prevent folks from just willy-nilly sharing data or biospecimens that come from Indigenous-led research, because that is different, and their data needs to be treated as such. But we already have a lot of great stuff to build on, so we're not starting from scratch here. And there's the one for tissue and biospecimens. And we also have a lot of great resources and partners and others that can help us work on difficult issues like, and complex issues like Indigenous-led research and data and biospecimens that are collected through those kinds of research projects. We have the Indigenous Working Group, which with HDRNet Canada, that's our group. That's not our group, but it's another group like us under HDRNet Canada. And of course, research with Indigenous populations, we all know, calls for different substantive and procedural ethics reviews. But there's so many great partners out there that can lead the Indigenous partners that can lead the way in this area or can partner with us. And it's going to be hard work doing the right thing, but it's going to be so much better in the end, I think. Also, engaging publics and patients to establish good governance mechanisms. You know, not so long ago, this was kind of a new novel idea, but what I see happening is these new projects that are being established, and just some of the ones that I listed on that one slide, but many others. It's just a natural thing now to want to engage patients and publics in every aspect of your research project now, where it's appropriate, even at the grant writing stage and idea development stage. I think it's great. I think people understand the benefit that you can get from engaging people right from the start and throughout your whole process. I know for the CHEER project, certainly that's something that's fundamental to the CHEER project, is engaging patients and publics throughout, and we've reaped the benefits of it. So I think that's kind of great. That's a huge step forward, I think, for the bioethics community. That being said, though, I think that as a community, as a whole research community, all of us, privacy, research ethics, bioethicists, researchers, everybody, we need to kind of do a big old cultural shift and remember why we're here. And the only reason we're here is to serve patients and publics. That's it. I think that's what it all boils down to. I put the plumb line there. Like that's what we should, or it should be orienting all our work. We should always be thinking about that. And I'm as guilty as anybody else that I love a good process, especially if I put tons and tons of work into it and it makes my life easier, and or a great template. I love that kind of stuff. But if it is not working, or if it is leading to an unethical outcome, or something that, that doesn't benefit patients, get rid of it. Modify it, look at it again. I mean, that's again why it's so incredibly helpful and useful to engage with publics and patients throughout your work, even for us. But I think we need to keep reminding ourselves of that. We get so in love with these processes that we've created that we can't see past them. And remember, they're just creations. We just created them. We can change them. We can do something. We can do things that are different, right? And I think in our world of bioethics, whoever you are, I think it does help to go back to basics, because we have all sorts of tools that can help us work with these really challenging, complex topics that are coming at us and that we're dealing with right now. One is, our applied ethics principles. These are the ones I use in my work. That's how the ones I was trained on. But of course, there's lots of different bioethics principles. These aren't the ones that are in Tri-Council policy statement, but that's okay. They force us to make all things considered judgments by considering all relevant information. So autonomy, beneficence, non-maleficence, justice, do good, don't do harm, try to help make people make good decisions for themselves, and justice, do what's in the best interest of all people, including the just distribution of resources and services, which is an ethics issue. So if we were over reviewing, if we are going well beyond what we need to, that's an ethics issue, because we're using up resources that could go elsewhere. And conceptual frameworks. It's good to be grounded in a nice conceptual framework. And this is a common one from bioethics that I use in my work, the difference between substantive and procedural ethics. So substantive ethics are the moral values that guide us through our work. Procedural ethics, doing things properly, like a beautifully constructed consent form, for example. They have to be patient-centered, and you need to pay attention to both of them in order to achieve just outcomes. So we can't just have a beautiful process and forget about the substantive ethics of our work, right? We have to do both. And then I just want to bring out this little chestnut. I love it. My mentor wrote it, but that's not why I love it. I think it's kind of great. It's a framework of ethical decision making, and I put the link there if anybody wants to access it. I'm going to go through just the big headlines here, but I feel like it's a very helpful framework to think about when I feel frozen and I feel like I don't know what to do, and I can't, look at what we did in the past because we never did this in the past and no one else is doing it. So, and you feel kind of stuck. We have tools to help us in times like that where we feel stuck and we feel frozen. We can start out by collecting information and identifying the problem. Isn't it interesting how oftentimes our clients will come to us, and usually when things come to me, it's because it's a dumpster fire, like something really bad has happened, everyone's mad at each other, and then they come to me. And it's common that, when we talk it out, sometimes we're not even talking about the same issue. So we have to that's the first thing we need to do, is identify what is the problem here. And one of the issues that we have really identified in our privacy group is this a legislative barrier or is this interpretation? And when we started to pull it apart and dig into it, we're thinking there is a lot more flexibility here than we thought there was. A lot of this is about interpretation and not legislative constraints. We have to think about feasible alternatives. There's almost always more alternatives available to you than you think there are. Even when you think about data sharing, if you really cannot move your data out of a jurisdiction or whatever, for whatever reason, well, what about exploring artificial intelligence? And maybe that's a way to get around it. So you're not actually bringing the data together anymore. It's learning from this data set and then going and learning from that. There's always different alternatives available to you. But when we think about those alternatives, we have to think about the morally significant factors in each one. And we can use our ethics resources to help us do that. Think about your principles. I use a little thought experiment is, what would my moral model do? I have some moral models in my life. I think, what would that person do in this situation? This person do in that? It just helps you kind of think about all things. Being part of a multidisciplinary team is a great way to help you think about alternatives and consequences, because all of us kind of have our own piece of the pie and our little sliver of expertise. But when we all come together with patients and publics when appropriate, wow, we can really make all things considered judgments together. It's important to propose and test solutions and resolutions to see, you know, what would happen if we went down this path? You know, would we actually end up in a better place? And then most importantly, we have to make our choice. We have to live with it and learn from it. I think it's so important for us to acknowledge that we are going to be making mistakes, guys, going forward. This is a brand new world. When we're talking about moving data that has never been moved before and all of the things that we're doing and new consent form, we just rolled out something this morning that I shouldn't go into it, but I will. It's a COVID study, and we took a lot of time writing this consent text we thought was great. And when we rolled it out, the patients said, I don't like it, I don't understand it. And we had to immediately change it. And so we've been doing that this morning, you know, on the fly. That you do your best effort, but then you have to be nimble. You have to be willing to be flexible and modify things. And, you know, there probably will be a privacy breach in our future and ethics deviations and stuff like that. But the important thing is not that we never make a mistake, because that's impossible. The important thing is that we learn from it. And we're kind to each other, as our Dr. Bonnie Henry would say in BC, and considerate with each other, and learn. We can learn from each other's mistakes. We don't, you know, it can be a learning experience instead of some horrible thing. And this is my last slide. I'm just pointing out some of the huge, big challenges that we're going to be facing now and in the near future. And I believe I don't see a way to do any of these things without a multidisciplinary approach, together with scientists, researchers, you know, patients and publics and everybody together working really, really hard. This work is very, very hard. How are we going to follow the OCAP principles of community engaged research, you know, ownership, control, access, and possession? How are we going to honor those obligations that we have to Indigenous people? That's going to be some hard work, and it's going to mean that we're going to have to give up a lot of control and do our work very differently. But like I said before, I think it's going to be so much better. It's going to be better in the end. How do we encourage different models of consent, integrated verbal consent in the clinic that have less burden on patients and staff? You know, there's folks in the bioethics community that are writing great pieces about this right now and doing their own research on it. When are we going to start using it in the healthcare system? How do we manage unspecified future uses in genetics topics like whole genome sequencing with special populations? That's a whole bucket of work right there. How do you ensure meaningful continued public engagement to support good governance and data sharing? So we don't want to just ask patients and the public, various publics once about what they want. We want to be able to get constant feedback. You know, is what we're doing working? Do we need to change? Do we need to be nimble? How are we going to build that into our systems? Because it's not really built into our systems right now. But I think with things like Cheer, we could do that because you're starting it from scratch. And how do you modernize compliance mechanisms within institutions to keep up with research and patient preferences and those of publics? It's a big one. Many of us are dealing with the fact that our systems, not only were they not intended to share data with research, they were intended not to share. That's how they were built to not do that. So again, it's not like turning on the tap and all our work is done. There's there's a lot of money that probably needs to put in this, resources, time, to develop these new processes and platforms and whatnot to serve the research community that will ultimately serve the health of patients and the public. So that's it for me, and I'm going to turn it over to our Donna, our leader. And you tell me when you want me to put a slide.
Okay. Thanks, Holly, and thanks, Charles. So for the last part, what we thought we would do is, and Holly just mentioned it, you know, we have to be willing to try. This is one of the things. We know there's this complexity. We are dealing with multiple layers of requirements and all the legislation and all the reality of that is administrative data research work. And so we called our whole presentation, we actually called it, so you can go to the first slide, we called it Demystifying Privacy. And so we said, let's do demystification. It didn't come up as a spell check, so I'm saying it's a word. So it's like, how can we help to remove the mystery around consent and linking to administrative data? So this is what we thought we would do, is share what we've been doing with you. And as a pan-Canadian group, and Charles mentioned the goals of the group is like we want to build these harmonized ways of approaching some of the problems that we're all facing together. So things that we can adopt together. So if you can go to the next slide, Holly. So one of the mysteries, of course, is around this idea of linking to administrative data. So what's happening there? And when I'm talking about linking to administrative data, I'm talking about linking any kind of data set. Maybe it could be a clinical data set, it could be some bio informatics kind of work, that kind of thing. So there's this mystery around the linking to administrative data. And why? Because, well, first of all, there's just a lack of awareness that there is a consent requirement. There's a misunderstanding about that, the idea of secondary use of data sets. There's an education piece there. Consent is needless regardless, even if it's intended for one-time use or it's an ongoing genomic study. So like these kind of things, sometimes people understand that for a big study or building a biobank, they might understand the consent idea, but maybe for one-time use in a very specific project to link to a data, they're not getting the understanding there. The approval to link is required prior to data collection. I cannot say this one enough. This has to happen right at the beginning. There is a lack of understanding around the terminology, and we're all guilty of this. All de-identified data, what do we mean by that? What do we mean by data linking versus data matching? People will say, oh, we used anonymous data, but actually what they used was pseudonymous data. So like there's this whole lexicon out there. There's different requirements across Canadian jurisdictions. So if you're doing a multiple jurisdictional research work and you've got Alberta involved and you've got Nova Scotia involved and people, you've got different rules in different places, like how do you come up with consent in that kind of environment? And then we have the numerous types and definitions of consent. I just did a quick search on that before this, and I realized I've been collecting, information on consent terms, and I'm up to like 16, 17 types of consent, and then navigating layers of guidance and policy and requirements. And so this isn't just legislation and the Tri-Council. This is like from our, oversight organizations or the data center you're getting the data from, or like just all these other like multiple layers. So this is where the mystery's coming from. We have to recognize that. It's not easy. There's no way around it. So I guess the next slide would be good. I did want to say too that nothing is more heartbreaking as a reviewer than to be looking at an amazing application to access administrative data and have to say no, because you're looking at it and all this work was done, all this data was collected, and now the opportunity or the methodology they would like to connect to administrative data, and we can't allow it because this whole mystery has not been addressed at the beginning. And so that's what, as privacy officers, as reviewers, we said, okay, what can we do? What's the first steps we can do? And so a solution that we've identified is that we needed a tool. How can we share a tool? And we wanted that tool to be, we thought, a set of guidelines, because we wanted to be able to both educate and inform, because you're not always going to have to do things. There is waiver of consent. It's not always that kind of, but you need to be informed of when and when not to. And we needed to educate people about the processes. We wanted to provide information on what to include in the consent process. So you're going to move forward. What do you need? And then we wanted to have that set of harmonized minimum best practices, because again, the reality is we're working in multiple jurisdictions with multiple layers of requirements. So what's the minimum? Where can we set that bar? And then it had to be useful for the spectrum of the research stakeholders. So it had to be of value. The tool, we wanted it to be of value to patients. We wanted it to be of value to researchers, data custodians who are making decisions about access, and REBs, people who are doing the review. And I'm sure there's other populations that I have missed, but we wanted it to be useful. So the next slide. So to start with, we did decide on a shared definition of what we meant by data linking, and we went with the Tri-Council because the definition there is, it's bang on, it's simple, and it's to the point. And basically, we're talking about the merging of analysis of two or more separate data sets. So yeah, the merger or analysis of two. So, and this is where, you know, we had to have that in common. We also have to have that understanding that proper data sharing agreements would be in place between the data business owner or the PI, or let's say it was a qualitative study that was done, a survey, and they want to link it to administrative data. That there has to be that proper arrangement in place. So the agreement has to be there. REB approval was sought prior to any data linking. I have to keep emphasizing that we do this up front, because nothing is worse than someone putting in their application and they've been banking on this idea of linking. And then finally, consent for data linking, recognizing this is just one little piece of the entire consent process. And that we wanted to be mindful of that as well today, that we are very aware of all of the demands. Like, you know, you look at these information sheets about a project that someone might be participating in, it's just pages and pages of information for them to digest. And how can you have informed consent? So we recognize that. So we wanted it to understand that we wanted to make things simple, because this is just one added piece to the bigger equation. So the next slide. So this is just a quick snapshot of what we prepared. And what we did is we took this and we put it together. We put, as Holly said, hours and hours of information went into it. We formed a working group, and Charles and Holly were part of this. We also had colleagues, Mary at Chi High, and Alison Papricia who's part of the Health Data Research Network Canada. She's part of the organization there, and they all contributed to this. And so if you go to the next slide, you'll see that what we did for an approach on this is we went down three streams or three fronts. And we tried to take we tried to provide a regulatory explanation. We tried to provide lay language of what is required. So it's one thing to say, this is what's required, and quote from a policy or quote from a piece of legislation. But what does that mean in, you know, really lay language? And then we tried to provide example tests of what would be found maybe in a consent piece. So if you go to the next slide, and these are all the areas of content that we included. So we looked at, when we built these, I should say as well, that we built this content based on what we were finding in the legislation, finding in the Tri-Council, finding in our other policies that we have to follow. So we tried to speak to data types and the linking activity. These are things you need to include. The linkage options, use of personal and unique identifiers. These are all the different pieces that we tried to include in the actual consent form. And then what we, or not, I shouldn't say consent form, in our guidelines. And so if you go to the last slide, then what we did, and this is the part that I cannot tell you how rewarding this has been. We put everything together and we sent it out in a draft in early December and said, just share it with everybody. And we meant everybody. And it's just amazing. We sent it to anybody we thought might be interested, anybody we knew that was doing data linking work, REBs. We sent it to patients. We used the patient advisory committee of the Health Data Research Network. And then they passed it on to other folks, anybody who would listen, who would send back. It was great. I even got emails back from people who said, well, I didn't look at it, but I sent it to this person who sent it to this person who said it. Great. And then the reviews came back, and we just got the reviews. The deadline was January 15th. So it's just passed. And what has been so fascinating, they're still trickling in this week. I'm still getting some of the responses back, and they're so informative. And the part that I have to say I'm so impressed with is that we seem to be bang on for the topic. I'm really like, people want this tool. Like, this is a tool that people are welcoming, and we have such great support for it. And they've provided solid feedback on changing the wording, glossary, maybe a bit more around definitions to make it more understandable. And I really, really cannot say enough about how appreciative I am from the patient point of view and the citizen engagement, and from their perspective saying, this example here isn't clear, or this one, I just don't know what you mean by this word, or, you know, so it's just been really informative. So our next step, what's happening right now, is we're going to compile the feedback, make the edits, put together our final version. We'll send that out for one more sort of cursory review, just sort of, you know, to all the usual suspects, make sure things are okay. And then we'll send it for translation into French, and hopefully it'll be made available. And of course, one obvious place is to have it available in the Data Access Support Hub through the Health Data Research Network Canada. But we're going to farm it out there. And like Holly said, if it's not the best, then we'll find out. People will let us know. We'll make changes. But the part that I'm really proud of is that we're trying to do something. It's a small step, but it's a solid step. And we're starting to move forward. And hopefully it's going to sort of demystify some of the process around linking to administrative data when you have a really amazing data set that you've collected and you want to add that extra enhancement of linking to the secondary use of data. All right. So that's really what I want to say. I just wanted to sort of showcase our piece. So.
Thanks, Donna. And just so everybody knows too, at the end of the day, the product is like this short little blurb that you can add on to your consent form that will permit data sharing that, and data access and sharing that you could not do before. And this little bit of text does a tremendous amount of work in all sorts of requirements. So we'll make sure everybody gets can, maybe from this group or something, or cheer will certainly get a copy of it.
Yeah, and we will still take feedback. Like we're so appreciative of it. So
yeah. So with that, we're happy to take any kind of questions that you may have. The question period will, as I said 4,000 times already, will not be recorded, so you can feel free to